Good afternoon, everyone. My name is Caroline Craven, and I'm the Chief Toxicologist with Mako Medical Laboratories. I first off just want to say thank you all for joining and attending the webinar today. I will be giving a presentation on understanding the sources of morphine and toxicology testing results. Just a few learning objectives that we will cover today. We will do a brief overview of morphine history and its clinical use. We will also have a brief overview of the pharmacology and toxicology for morphine. We will identify challenges associated with the interpretation of morphine-positive results. We will identify the 4 recognized sources of morphine, and we will also review examples of morphine-positive results and their possible interpretations. So first, we'll start off with the history of morphine. Morphine is derived from the opium poppy plant. Its first use dates back over 2,000 years during the mid-1800s. And today it's currently used worldwide to treat moderate to severe pain in both acute and chronic pain patients. Pharmacology and toxicology. So first we're going to talk about the pharmacodynamics. Morphine, it exerts its main effect by binding to and activating the mu-opioid receptors in the central nervous system. It also has affinity for the kappa and delta opioid receptors as well. In clinical settings, morphine exerts its principal pharmacological effect on the central nervous system and the gastrointestinal tract, where the primary actions of therapeutic value are analgesia and sedation. Specifically, if the mu-opioid receptor is activated, the associated effects of that are analgesia, sedation, euphoria, physical dependence, and respiratory depression. So now to talk a little bit about the pharmacokinetics of morphine. Morphine can be administered orally, intravenously, rectally, subcutaneously, as well as through inhalation or snorting. Morphine has a significant amount of first-pass metabolism in the liver, and only around 40 to 50% of the amount absorbed actually reaches the target tissue or organ. Morphine is metabolized primarily into morphine 3-glucuronide and morphine 6-glucuronide via glucuronidation by phase 2 metabolized enzyme UGT2B7. Most of morphine is processed and eliminated from the body in urine, where 87% of the dose is excreted within 72 hours of administration. So now we're going to cover some toxicology interpretation challenges that are associated with morphine. When morphine is detected in a urine, a clinician's next step is determining its origin. One challenge with morphine is that it has various sources. There are 4 recognized sources of morphine that include codeine, heroin, morphine, and poppy seed ingestion. These sources can cause confusion and misinterpretation in pain management. It is incumbent on the clinician to ask questions that may provide insight into possible sources. Examples of such questions include: does the patient have a history of heroin abuse? Does the patient have a prescription for codeine or morphine from another provider? Has the patient recently consumed a codeine-containing product, such as a cough syrup? Has the patient recently consumed a food that contains poppy seeds? In some cases, further evaluation, such as testing for codeine or the heroin metabolite 6-monoacetylmorphine, may be needed to determine the exact source. Since the presence of morphine can result from expected sources, such as a prescription for morphine, or from unexpected sources, such as the abuse of a prescription or use of illicit drugs. It is imperative that clinicians understand the various sources of morphine in order to better understand the origin of the morphine-positive in toxicology testing. So here you can see the 4 different sources listed and their expected or possible analytes that you would see in a toxicology test. If heroin is consumed, the expected and possible analytes are the heroin metabolite 6-monoacetylmorphine as well as morphine. If codeine is consumed, the expected and possible analytes include codeine, morphine, and hydrocodone as a minor metabolite. If morphine is consumed, the expected and possible analytes include morphine, hydromorphone, which is a minor metabolite of morphine, and then codeine, which is a manufacturing process impurity. And then lastly, there we have poppy seeds, and the expected and possible analyte for that would be morphine. So now we're going to go through each individual source and provide a little bit of background on those, as well as some detection times. Heroin, also known as diacetylmorphine, is rapidly metabolized from diacetylmorphine to 6-monoacetylmorphine, which is oftentimes referred to as 6-MAM. 6-MAM is then subsequently metabolized to morphine. Diacetylmorphine and its metabolite 6-MAM have very short half-lives, thus making detection difficult. The typical detection time there is 8 to 24 hours. The only source for 6-MAM, the heroin metabolite, is heroin. Thus, if it is detected as positive in a toxicology test, it would be concluded that the individual had recently ingested heroin. In the event that only morphine is present, it may be difficult to determine whether heroin has been consumed and is a viable reason for the positive morphine, even though the presence of large quantities of morphine may be an indicator of heroin consumption. In this particular situation, it may be necessary for a clinician to ask questions regarding heroin use or why the patient has an unexpected positive morphine result. So here's an example of a heroin positive report. No prescription for codeine or morphine was reported. And here you can see that we did an opiate screen where the opiates were detected. We did further definitive confirmation testing. We did detect the heroin metabolite 6-MAM at 56 nanograms per milliliter. And then we also detected morphine at 1,248 nanograms per milliliter. So this would be a good example of where heroin was the contributing source to the morphine. Next, we have codeine. Codeine is commonly marketed and prescribed as the prescription Tylenol with codeine or as a cough syrup that contains codeine. It is a prodrug that is metabolized to morphine after administration through the cytochrome P450 2D6 enzymatic pathway. In individuals who have consumed a codeine prescription, the expected urine drug test result should demonstrate the presence of both codeine and morphine. However, it is important to recognize that if a patient is taking a codeine medication as a PRN or on an as-needed basis, and it's been a day or two since dosing, it is possible that only morphine may be detected. Here's an example of a codeine patient report. Tylenol 3 with codeine was listed as being prescribed. Again, here we did the opiate screening test where it was detected. We did further definitive mass spec confirmation, and here you can see that we did detect codeine at greater than 2,500 and morphine at 386. So this would be a good example of where codeine was the source of morphine. Next, we have morphine. So morphine is commonly prescribed as MS Cotton, Codeine, and Embeta. When it is prescribed and consumed, the expected toxicology test result should demonstrate the presence of morphine. In some circumstances, a small amount of hydromorphone or codeine may be detected as well. Hydromorphone is a minor metabolite of morphine and may be detected after consumption of high doses of morphine. Also, codeine may be detected in low amounts due to a contaminant from the manufacturing process of morphine. There is an allowable pharmaceutical process impurity for codeine during the manufacturing of morphine at 1.15%. The presence of hydromorphone and or codeine is not necessarily expected routinely, but it is possible for their presence in patients who are being prescribed morphine. So here in the first morphine example, we have a patient that was listed as being prescribed MS Cotton. And here you can see we did the opiate screen, which we did detect. And then we also found morphine only at 1,996. Next, in our second morphine example, MS cotton was listed as being prescribed. We did find that at greater than 2,500, and we also found low levels of hydromorphone at 234. So this would be an example of where hydromorphone was present due to it being a minor metabolite. And then the third example here, MS cotton was listed as being prescribed, and codeine was present at low levels. And this would be an example of where that pharmaceutical process impurity is taking place. So we have morphine at greater than 2,500 and codeine at 125. And then the last source we have was poppy seeds. Poppy seeds are commonly found on bagels, in certain breads and cakes, as well as being used in other foods or cooking methods. Ingestions of poppy seeds can produce low-level positive morphine results on a toxicology report. The amount of morphine present is often less than 2,000 nanograms per milliliter following poppy seed consumption, although it is possible for higher concentrations to be present. If low levels of morphine are present, a detailed patient history may aid in determining whether poppy seeds have been consumed recently and if they are the contributing factor to a positive toxicology test result. So here you can see an example of a low-level morphine that was detected, possibly resulting from consumption of poppy seeds, as no prescription for morphine or codeine was reported for this individual. So here we found a morphine positive at 104 nanograms per milliliter. So that covers the 4 individual sources for morphine and possible interpretations for them. Again, that's codeine, morphine, heroin, and poppy seed consumption. I want to thank you all for your time and allowing me to give you this presentation on the 4 sources of morphine and understanding toxicology interpretations. At this time, I will open the table for questions or comments. You can use the chat box that you have there to type in any questions, or you can also contact us at info@makomedical.com.